Hello everyone. Today I'm going to talk about diseases of the nervous system. The lecture is going to be divided into diseases of the peripheral nervous system and diseases of the central nervous system. I'm going to start with the peripheral nervous system first because it is quite straightforward and more simple than the central nervous system. Neuromuscular diseases are characterized by weakness, muscle pain, or sensory deficits. They can be divided into diseases of the peripheral nerve, diseases of the neuromuscular junction, and diseases of the skeletal muscle. The nervous system can be grouped into two main parts: the central nervous system and the peripheral nervous system. The central nervous system includes the spinal cord, the brainstem, and the brain, whereas the peripheral nervous system can be grouped into the autonomic nervous system and somatic nervous system. The figure here shows two normal motor units. One motor unit is defined as the muscle fibers that are innervated by one motor neuron. So the type of the muscle fiber is determined by the motor neuron they are innervated. So if this neuron is programmed to supply muscle fiber type 1, for example, every fiber in this group will be muscle fiber type 1. Whereas if another motor neuron is programmed to supply muscle fiber type 2, all fibers in the group will be type 2. So normally type 1 and type 2 muscle fibers are interspersed amongst each other in a checkerboard pattern. So a normal motor neuron, just like most motor neurons are multipolar neurons, right? And the axon is wrapped by myelin sheath, which is produced by Schwann cell. And the cell that is equivalent to the Schwann cell in the central nervous system is oligodendrocyte. Yes, they are quite similar, but not the same. Anyway, the myelin sheath helps nerve conduction so that the action potential can move forward very quickly to the nodes of ganglia. So they skip the areas with myelin sheath, and so the nerve conduction is quite quick with myelin sheath. Some diseases affect mainly the axon. So those diseases are called axonal degeneration. So the axon is destroyed first, and then the myelin sheath will be degraded later. The result is denervation, atrophy of the affected motor unit. So the muscle fibers supplied, innervated by this motor neuron will be atrophic, right? Whereas the motor fibers innervated by normal motor neuron will be unaffected. Right? So this is axonal degeneration or axonopathy. some diseases affect mainly the myelin sheath. So these diseases are called demyelination. So the axon will be intact, will be normal until very late in the course of the disease progression. So the problem is with the myelin sheath. So the nerve conduction is much slower than normal motor neurons. So the patients may become weak, may suffer weakness as well. So the axon will be degenerated very late. So the myelin sheath is destroyed first. So some diseases are like this. When the nerve is cut or injured, the nerve can, just like the axon, can grow. So this is the process of reinnervation. But the process is very slow, very slow. So the axon will grow about 1 millimeter per day. So it is very slow, but it is possible. However, the newly formed axon with myelin sheath will never be the same. The repaired or the new axon will have some degree of impaired function. When one motor unit is destroyed, the adjacent motor unit will take over the whole area. So it is possible that the unaffected motor unit will grow a branch of the axon to supply the previously atrophic muscle fiber. So, and as I mentioned previously, the type of muscle fiber is determined by the motor neuron that supply them. So when there is reinnervation of the adjacent motor unit, so the previously atrophic muscle fiber will be supplied by the adjacent motor unit instead. So the muscle fiber type is changed to according to the new motor unit they belong to. So we can see that after axonal injury and reinnervation, the checkerboard pattern is gone. The checkerboard pattern as seen here is gone. So when we see the loss of the checkerboard pattern, we can know exactly that there is something wrong with this area. There must be some motor units that have been destroyed, and the muscle fibers are supplied by adjacent unaffected motor units instead. So the checkerboard pattern is gone. And another group of diseases is the myopathy. So in this group of diseases, the axon, the neuron, and the myelin sheath are well, they are normal. But the problem is with the muscle fiber. So we will see muscle atrophy without anything wrong with the neurons or the myelin sheath. And diseases of the peripheral nervous system can be discerned, can be grouped broadly by the distribution of the neuropathy. So if we know the distribution, we can guess or we can hypothesize the causes of the disease. If the distribution is at only one area or the areas supplied by one single nerve, that is mononeuropathy. So we can hypothesize that the cause of the problem may be trauma, entrapment, or infection. Entrapment problems are very common, as you must have studied already about carpal tunnel syndrome, for example. That is one example of entrapment injury. That is mononeuropathy. The second type of the anatomic pattern of the peripheral neuropathies is polyneuropathies. So poly means multiple, right? So multiple nerves are affected by the disease. So the distribution is very typical. So the patients may explain that they have numbness, just they feel like wearing stockings and gloves all the time. So that is stocking and glove pattern. So because they will feel numbness at the distal extremities, both hands and both feet. So they will feel like they are wearing stockings, they are wearing gloves, even though they wear nothing. So these diseases usually affect the distal parts of the extremities first until they progress proximally to the upper to the proximal parts. And the third group is mononeuritis multiplex. The name is quite complex, right? Name is quite complex. So at the first part, it says it is mononeuritis, meaning that only one nerve is affected. But what about multiplex, which means multiple, right? So this group of disease is quite interesting. So both single and multiple. So the definition of this pattern is damages of several nerves in a haphazard pattern. Several nerves in a haphazard pattern, meaning that we cannot predict which area of the body will be affected. Maybe one nerve here, one nerve there. So the distribution is quite haphazard. So this is very typical for vasculitis. And the third group is polyradiculoneuropathy. Poly means multiple. Radicular nerve root neuropathy, the problem with the nerves. So there is a problem with the nerve affecting the nerve root and multiple nerve roots. So the disease affects nerve roots and peripheral nerves. So the patients will suffer weakness or sensory loss symmetrically. So the disease will affect both proximal and distal parts of the body. So this group of diseases is quite severe, and one example for this pattern is Guillain-Barre syndrome, as I will mention later on. So I would like to move to specific peripheral neuropathies. So there are many types of peripheral neuropathies. I am going to focus on only some that I think they are important for you and you must know. For infectious diseases, the typical example is leprosy. I would like to let you study about it later when you study microbiology and immunology. So you will learn about this later on. So I should skip this one to save the time. So I'm going to focus on Guillain-Barré Syndrome, diabetes mellitus, diabetic neuropathy, and Carpal tunnel syndrome for the peripheral neuropathies. Guillain-Barré Syndrome. So the name is quite strange. I would like you to remember the full name. Even though the full name is very long, but the name explains a lot about the disease. Acute inflammatory demyelinating polyradicular neuropathy. Acute inflammatory demyelinating polyradicular neuropathy. So the disease is quite acute. The onset is quite quick. Inflammatory, meaning that the disease is caused by immunologic mechanism. Demyelinating implies that the disease mainly affects the myelin sheath. So the immune mechanism destroys myelin sheath. And polyradicular neuropathy tells us that the distribution of the disease is both proximal and distal parts of the body. The disease affects nerve roots and peripheral nerves. So this condition, this syndrome can be life-threatening. The pathogenesis is immune-mediated. The typical history is the previous history of vaccination or infection. Any infection, any vaccination can be the predisposing factor for this condition. So 60 to 70% of the patients report the recent history of vaccination or infection. If you read the textbook, one typical infection that is frequently mentioned is Campylobacter jejuni, which causes diarrhea, which causes enteritis. So this is one typical example. However, any vaccination, any infection, any viral infection or mycoplasma infection or bacterial infection, they all can cause Guillain-Barré syndrome. And the condition is T-cell mediated or circulating antibody mediated. We detect both antibody and T-cell that is directed to the myelin sheath. Guillain-Barré syndrome affects nerves in the brain and in the spinal cord. It affects nerve roots and peripheral nerves. So normal nerve is grabbed by myelin sheath, but in this condition, the myelin sheath is destroyed by the immune-mediated mechanism. Histologically, we detect infiltration of lymphocytes within the nerves. These lymphocytes come to destroy myelin sheath. And most patients are preceded by infections such as Campylobacter jejuni, enteritis, and the syndrome will start, the symptoms and signs will start at the lower part of the body first. So we will see the phenomenon described as ascending paralysis and aliflexia, symmetrical muscle weakness, and the weakness is ascending from feet to legs to thighs to the body to upper extremities. So the condition usually begins in the legs and ascends. So just remember symmetrical muscle weakness. I think that explains a lot. And the patients will complain of sensory deficit also, but it is not a predominant feature. And the big problem will come when the weakness affects the diaphragm. So the patients may suffer respiratory paralysis and also autonomic instability. So it is important that the treatment is started in time, on time. So the main modalities of disease modifying therapy for Guillain-Barré syndrome are plasma exchange and intravenous immunoglobulin. And the next group of neuropathies I would like to mention is metabolic one, diabetic neuropathies. It is the most common cause of peripheral neuropathy, and the typical presentation is ascending distal symmetric sensorineural polyneuropathy. Ascending meaning that the symptoms start at the distal parts of the hands and feet, and then the numbness, the sensory neural loss will affect the distal parts, and the sensory loss is symmetrical, both hands, both feet about the same. So one test that we would do when we examine diabetic patients is to determine whether they have sensory loss on their feet and on their hands or not. So we may use something that is sharp to put on their hands and their feet and ask them if they feel that the thing that we put on is sharp or not. If they have some degree of diabetic neuropathy, they will tell that no, it is not sharp at all. So they will not feel that it is sharp. So that is a sign of diabetic neuropathy. So the pathogenesis of this condition is non-enzymatic protein glycation. It is the formation of the advanced glycosylation end product AGE, advanced glycosylation end product AGE. It is one major mechanism for diabetic nephropathy also. And it is the binding of the sugar to the protein without the use of the enzyme. And another mechanism is polio-mediated damage. The sorbitol is formed, so there is osmotic injury to the nerve, to the myelin sheath, and there is damage. And another mechanism, another pathogenetic process is diabetic microvascular disease with secondary ischemic injury. So can you recall the name of the blood vessels that supply nerves? Okay, just consult your textbook. It is vasa nervorum. Okay, this is one healthy nerve. So it is this is the nerve, and the nerve is supplied by blood vessel called vasa nervorum. Vasa nervorum. And the problem will be seen when there is damage in the diabetic patients. The vasa nervorum is occluded, and the nerve fibers are also damaged. Both myelinated and unmyelinated nerve fibers are affected. This image shows the ultrastructural changes seen in diabetic neuropathies. So we can see loss of myelinated fibers, and thinly myelinated fiber is seen in the narrow head here, and there is thickening of the endoneural blood vessel. So diabetic foot is a major problem that can be seen amongst diabetic patients because they have both vascular occlusions and neuropathies. So neuropathies will predispose them to injuries. So they tend to have ulcers, they tend to have wounds on their feet, and vasculopathy, vascular occlusions by atherosclerosis or by any forms of arteriosclerosis will predispose them to poor wound healing. So they will be easy to have wounds, and the wounds are very difficult to be healed. So that's why some patients have to have amputation, leg amputation, foot amputation. So we have to take care of diabetic patients very well, and we have to give them adequate information to make them aware of the danger that they can have if they don't take care of their feet very well. Here is a picture demonstrating the diabetic foot. So they can step on the needles without feeling anything, without any pain. And the next group of neuropathies I would like to mention is carpal tunnel syndrome. Carpal tunnel syndrome is the most common compression or entrapment neuropathy. So there are different causes of this condition. Edema from any cause, maybe from congestive heart failure, maybe from nephrotic syndrome, maybe from chronic liver disease, and pregnancy, and degenerative joint disease. Hypothyroidism is also another predisposing factor for carpal tunnel syndrome. There is increased extracellular matrix production, and amyloidosis and excessive grist juices. And this figure shows the anatomy of the carpal tunnel. So carpal tunnel is covered by the transverse carpal ligament, and there is a nerve passing through this tunnel, which is the median nerve. Median nerve here. So this is the distribution of sensory nerve supply to the hand. So the median nerve supplies the sensation at the palmar side of the hand, on the first, second, third, and half of the fourth fingers. So when there is entrapment here, when there is increased content here, when there is increased connective tissue here, or when there is edema, this nerve is entrapped, is compressed. So we will have some signs and symptoms attributing to median nerve injury. So early in the course, the patient may complain of tingling or numbness on the hands. So at the first, second, third, and half of the fourth fingers. And later in the course of the disease, the patients may develop thenar muscle atrophy. So the numbness or the tingling or the pain may be so severe that it wakes the patients up at night. And when there is thenar muscle atrophy, the only treatment option is surgery. So early in the course, we may advise the patient to do physical therapy. We may just like physical therapy helps a lot. But when there is thenar muscle atrophy, the treatment option is only surgery, and the surgery does not guarantee that the muscle will become full again, will become strong again after surgery. There are also many other types of entrapment neuropathies. Carpal tunnel, the nerve is median nerve. Cubital tunnel, the nerve is ulnar. Spinal group syndrome, radial nerve. And ulnar canal, the ulnar nerve. Peroneal neuropathy, peroneal nerve. Tarsal tunnel syndrome, tibial nerve. So I know that you have learned about these anatomic locations already. So just correlate your anatomy knowledge to the clinical presentation of diseases. And one syndrome that I think you can recall is Saturday night syndrome. Right? Okay. And this one is an extra because the NL exam asked about this one just like recent year, in last year or previous year. So it's traumatic neuroma or amputation neuroma. Even though the name ends with oma, but it is not a neoplasm. It is a proliferative and hyperplastic response to nerve injury. So after amputation, we may see a mass, a firm mass, often painful at the amputation site. So this is traumatic neuroma. The trauma activates or stimulates proliferation and hyperplastic response of the nerve that has been cut. So we will see the reaction as a mass, which is often painful. So histologically, we see non-encapsulated, haphazardly proliferating masses of axons and Schwann cells within dense fibroconnective tissue. And the adjacent cut end of the injured nerve may also be seen. And the next group of the diseases of the peripheral nervous system is the problem with neuromuscular junction. So this group of diseases is characterized by painless weakness. Mechanistically, the diseases can be divided into antibody-mediated or toxin-mediated. Antibody-mediated conditions include myasthenia gravis and Lambert-Eaton myasthenic syndrome. The toxin-mediated conditions consist of botulism and Curie. So I would like to review a little bit about the nerve conduction at the neuromuscular junction. So the action potential comes along the axon and then reaches the nerve terminal, the presynaptic nerve terminal. And then there is activation of voltage-gated calcium channel first. Voltage-gated calcium channel. When calcium enters the nerve terminal, acetylcholine can be released. And the acetylcholine will bind to the acetylcholine receptor, which is on the motor end plate. The acetylcholine will activate action potential here, and then muscle contraction later on. After the use of the acetylcholine, this molecule will be destroyed, will be digested by acetylcholinesterase, which digests acetylcholine into acetate and choline. Choline will be reuptake and will be reused to produce acetylcholine in the presynaptic nerve terminal. And this figure demonstrates some diseases that affect this area. So myasthenia gravis is the blockade of acetylcholine receptor. It is in this disease there is antibody that binds acetylcholine receptor, resulting in inability of the acetylcholine to bind to its receptor. Another one, Lambert-Eaton syndrome. In this condition, the body antibody binds to presynaptic voltage-gated calcium channel, resulting in muscle weakness. And for botulism, the toxin inhibits secretion of acetylcholine. The toxin prevents the release of the acetylcholine from the presynaptic nerve terminal. So the patients will also have weakness. So here I am going to highlight myasthenia gravis and Lambert-Eaton myasthenic syndrome. Myasthenia gravis is usually seen in women before the age of 40. The pathogenesis, just remember this one, acetylcholine receptor autoantibodies. So the antibodies may block the acetylcholine binding, or they may cause damage to the postsynaptic membrane, or they may stimulate internalization or downregulation of the receptor. In this condition, the muscles that work all the time, will become fatigued, because when we activate the muscle contraction, the acetylcholine is released, and when it is released, the acetylcholine is digested by acetylcholine. So when there is repeated contraction of the muscle, the reserve of the acetylcholine within the vesicles are gone. So there is depletion of the acetylcholine reserve. So that is why after repeated stimulation, the weakness will become more and more. So the muscles that are affected frequently are extraocular muscle. So the patients may have ptosis หนังตาตก or diplopia เห็นภาพซ้อน These conditions result from the weakness of the extraocular muscles. The symptoms are worsened with repeated stimulation and the treatments are still anticholinesterases, prednisolone, and plasmapheresis. And one important point of this condition is its association with thymic pathology. Thymic pathology, not necessarily thymoma, maybe only thymic hyperplasia or thymoma. So most thymic pathology, thymic pathology seen in most cases is thymic hyperplasia, not thymoma. So when you answer, the association of this condition is thymic pathology, not thymoma, even though thymoma can also be seen. So the one treatment option for this condition is thymectomy. Even though we don't see anything wrong with the thymus, thymectomy will help a lot. The next condition is Lambert-Eaton myasthenic syndrome. This condition is also important. It may be a sign of more serious conditions inside, because 50% of this condition result from small cell lung cancer. Small cell lung cancer. It is also associated with other immune disorders such as vitiligo and Graves' disease. So the patients will present with weakness or autonomic dysfunction. In contrast to myasthenia gravis, the weakness will be improved after repeated stimulation. Why? The problem of this condition is at presynaptic voltage gated calcium channel, right? So when there is stimulation, the acetylcholine cannot be released. But when we repeat it again and again and again, so the signal will be strong enough to activate acetylcholine release from the presynaptic nerve terminal. So when acetylcholine is released to some amount, nerve muscle contraction can take place. So this condition is improved after repeated stimulation, and the treatment is immunosuppression or drugs that increase acetylcholine release by depolarizing the presynaptic membrane. So this table summarizes these two conditions. So myasthenia gravis is caused by antibodies to postsynaptic acetylcholine receptors. Symptoms are common. Association, this table is wrong. It is thymic pathology, not thymoma. Reflexes are usually normal unless you repeat the test for 100 times. So the patients will show some degree of weakness, but no one will do that, or the patients will punch at your face. So the reflex is normal because we stimulate only once. But if we stimulate again and again, repetitive movements, the symptoms will be worsen. So on the right side, Eaton, Lambert, or Lambert-Eaton. I don't see consensus on the name, whether Eaton is first or Lambert is first. So the pathogenesis is antibodies to presynaptic voltage gated calcium channel. Symptoms are not usual. Association is odd cell lung cancer. Odd cell lung cancer, odd cell carcinoma is an obsolete name of the small cell lung cancer. So the same. 50% of this condition is associated with paraneoplastic syndrome, and the most common type of cancer that causes this condition is small cell lung cancer. Reflexes will be decreased because we need to stimulate again and again until until muscle contraction can take place. So repetitive movement will improve the symptoms. So one guy tried to create one sentence that may help you remember, but I think it is more confusing than helping. Lambert enjoys eating oats. Eating will make one stronger with repetition. So Lambert-Eaton enjoys eating, meaning that it is associated with oat cell lung cancer. Because this person enjoys eating oats, and of course eating will make one stronger after repetition. So implying that in this condition, repeat it again and again, repeat simulation will improve the symptoms. So the last group of the disease of the peripheral nervous system, I would like to highlight one condition, muscular dystrophy, which just like two common muscular dystrophies are Duchenne and Becker. These two conditions, Duchenne and Becker muscular dystrophy, can also be called X-linked muscular dystrophy because they are inherited by X-linked recessive. So there is disruption of the function of the X-linked protein called dystrophin. Just remember the name, dystrophin. In Duchenne, there is no dystrophin at all. In Becker, there is some amount of dystrophin. So dystrophin is still present, but at low amount. So the problem is the mutation of the DMD gene, and the mutation results in defects in dystrophin glycoprotein complex. This complex is responsible for interconnection between the sarcomere between the muscle and outside the muscle. So it causes talks between outside the cells and inside the cells. So it is important, it is required for membrane integrity, because when there is nerve contraction, just like the connective tissue surrounding it should allow the muscle to contract, right? So when there is no crosstalks between the muscle fiber and the surrounding tissues, the membrane is broken. There is membrane break. So after muscle contraction, there will be small membrane tears and calcium influx if the muscle has no dystrophin glycoprotein complex, resulting in myofiber degeneration. So here, dystrophin glycoprotein complex. So there are a lot of proteins involved in this complex. So this complex links between the cytoplasm and the extracellular matrix. So it allows contact, allows crosstalk between them. So when there is muscle contraction, the adjacent connective tissue must allow the muscle to do so. But when there is no crosstalk, there will be membrane break every time the muscle contracts, resulting in muscle cell death. So in Duchenne, dystrophin is absolutely gone, whereas in Becker, dystrophin is still present at a lower level. So here is a muscle biopsy in these X-linked muscular dystrophies. We will see myofiber degeneration, we will see fibrosis, we will see inflammation. And one important sign for Becker for Duchenne muscular dystrophy is Gover's sign. Gover's sign. Because the weakness will affect the proximal muscle first. So when we tell the child to get up, the child cannot stand up normally like we do. He has to use his hand, use his arm to hold the knee, and then push his body to stretch up. And then when he stands, he usually use his hand to hold his hip, because his hip is so weak. He has muscle weakness at the thigh, at the hip area. So this is Gover sign. The weakness begins in the pelvic girdle muscles extending to the shoulder girdle. So after repeated injury to the muscle fibers, that is the position of extracellular matrix. So the patient's calf is big. This is called calf pseudo-hypertrophy. Calf pseudo-hypertrophy. It is not true hypertrophy. It is pseudo-hypertrophy because of extracellular matrix deposition, because of the repair process. And the disease progression for Duchenne muscular dystrophy is quite predictable. The children will suffer walking problems around the age of 2 to 10 years, about 5 years. And then at the age of 10, some may start to suffer just like they will have to use wheelchair because of skeletal deformity. And then later on, they will have limited use of arms. They will depend on ventilation at night, and they will totally depend on ventilation all the time. And then up to the age of 30, most of them will die. So it is so sad. So I hope that gene therapy will be successful soon to help the babies, the child that have this condition. That's all. Thank you for your attention, and then continue to another lecture on the central nervous system.